Good afternoon. Moving on from local intravesical therapies to systemic and more radical therapies. First, I would like to invite our respected chairpersons, Dr. Sabnis sir, Dr. Kekre sir, and Dr. Patwardhan madam.
We are gaining time. We request 5 minutes time saving on this session, and we will not have a break. Thereby, we can actually make up the time to again back to the genuine IST.
Our first speaker for this session is Dr. Atul Batra, who will be speaking on systemic therapy for high-grade recurrences.
So thank you organizers and chairpersons for giving me this opportunity to speak on systemic therapy in NMBIC. So I think we have already covered this in the previous talks, that why is this niche important to treat and what are the problems that are here. And we have covered the definitions of high-grade recurrence with BCG exposed, unresponsive and late relapse. So we'll come directly to what exactly systemic therapies do we have and why do we need it. So as previous speaker said that, Dr. Bora said, the standard of treatment remains radical cystectomy, and there are a few patients who deny this and a few patients who are ineligible for this here. And of course the kind of surgery that is related, the quality of life that remains after this is definitely not great. So we need something if we can spare bladder. And we have few studies which have looked into it. Today we'll be discussing Keynote 057 study which looked at pembrolizumab. So what is pembrolizumab and what is PD-1? Basically we know that tumor would evade the immunity, right? And what happens is it activates the PD-1 and PD-L1 pathway, which leads to the evasion of immunity. And PD-1 inhibitors basically reactivate the immunity and thus leading to cell kill by the own immunity. So pembrolizumab is one such PD-1 inhibitor, and this was the study designed for Keynote 057 study. Importantly, this was a single-arm open-label study and included patients who were high-risk NMIBC, who were unresponsive to BCG and who refused or were ineligible for cystectomy. There were two cohorts. Cohort A was in situ disease. They could have papillary disease, both were included with or without, and a cohort B which was papillary disease without in situ disease. These patients were treated with pembrolizumab that was given intravenously every 3 weeks, and the evaluations were done initially every 3 months for the first 2 years and then every 6 months. A CT urogram was done every 6 months for the first 2 years. The primary endpoint here was a complete response, which was defined as absence of high-risk disease in cohort A. Since cohort B had, the patients had to have fully resected disease at study entry, the primary endpoint here was disease-free survival from high-risk non-muscle invasive bladder cancer. So the first results of this study were presented in 2018 for cohort A, and for cohort B it was this year that it was presented at the ASCO GU symposium. So we'll first look at the cohort A results. 103 patients were initially presented, and later there were changes when it was finally published in Lancet Oncology. There were few patients who did not match the exact definitions, and they said 96 patients were treated properly. Of this, the patient's median age was 73 years. Everything was more or less what we see in the clinics, where the 70% of patients had CIS alone, whereas rest 30% had either T1 or TA in the disease. So overall, if you look at the complete response, there were around 40% patients who had complete response. So this was at month 3, and this was exciting. If 40% patients could have a complete response, then it's pretty good. But we were more interested in looking whether such complete responses, how long are these sustained? Are these temporary remissions or they are sustained for a longer time? But unfortunately, we saw that around 50% of the patients who had complete response at 3 months, this response was lost and there was recurrence in another 50%. So to begin with, 40% had CR, And of that, 50% had recurrence. So at the end of 1 year, we had only 19% patients who were still in complete response. But still encouraging because there's something to offer at least. So patients who were CR, of course, tend to remain in that, but around 50% lost it at the end of first year. Regarding adverse events, now over time we have learned how to give pembrolizumab and other PD-1 inhibitor like nivolumab. Initially, there were few newer kind of spectrum of side effects which we had not seen earlier with chemotherapy, but now we know how to manage these side effects, how this autoimmune things are functioning, how interstitial lung disease is treated. So this, here it was grade 3 to 4 side effects were around 12 to 13%, but these are more or less manageable now. We would be more interested in looking at positive results. Adverse events are now manageable. Now looking at cohort B had 132 patients, and this was presented just this year with a median follow-up of around 4 years at and 132 patients were treated with pembrolizumab. So these patients did not have in situ disease and just T1 or Ta disease. At the median follow-up of 45 months, the first year disease-free survival was 40%, and here we are seeing that there is some kind of plateau happening in around 1/3 of the patients. So around 35% of patients were disease-free at the end of 3 years, which looks a little more promising than the cohort A group. Having said that, this is a single-arm phase 2 study, and however, it did receive approval and incorporation in NCCN guidelines for such patients. Adverse events, again, no deaths, and more or less manageable now. It is all about suspicion of these side effects that need to be there, and then these are manageable. Now, when we looked at these, the results look a little modest to, 30-33%, but not what we exactly look at least 50-60% or 80%. So why not combine these agents with some kind of intravesical treatment? So here is what we discussed about TAR-200, which releases gemcitabine for over a longer duration. So when we give intravesical gemcitabine, there's a peak and then there's a washout. But with TAR-200, there's sustained over 7 days or so. And when this was combined, so this was the Sunrise 1, the results that were presented in AUA this year. Here again, we had a similar population, and this was 3-armed. So one arm had sertrelimab. This is again a similar to pembrolizumab drug. Then the second arm is TAR-200, that was intravesical, and a third arm which had a combination of both. So the planned recruitment was 100 patients in the combination arm and 50 patients in each TAR-200 alone or sertrelimab again alone. Primary endpoint again was overall CR rate that was determined by cystoscopy, and imaging that was performed at 6 months and at the end of 1 year. So the patient disposition again was more or less similar. This was not blind. These are just the results of the last 2 arms, not the combination arm. TAR-200 alone and sertrelimab alone. So this was more or less comparable in both the arms. But when we look at the results from TAR-200, the results do look promising. That we look at a CR rate of around 72.7% compared to 38%, again matching what we saw in the Keynote 057 study, again around 40%. Now what will happen with combination is a matter of speculation, and we need to see how these results mature with time. But the data with TAR-200 do look promising. With a short follow-up, we need to see how these data come up with the time and combination as well. So to conclude, PD-1 inhibitors have shown activity, but it is kind of modest. Pembrolizumab shows 40% patients would go into a complete remission, but that would not be sustained. At the end of 1 year, 20% will have a complete remission, but rest of the patients would have either recurred or would not have responded by then. It is somewhat better in patients who do not have an in situ disease, around 1/3 of patients. However, the data from TAR-200, that is again intravesical, look promising, and the data from TAR-200 and combining this with an IO therapy is much awaited. And radical cystectomy does remain the standard of care here, but patients who cannot or who do not want may be offered pembrolizumab. We have a very limited experience with pembrolizumab, not a positive one. there are some positive, there are some ongoing phase 3 studies where the incorporation of BCG with an immune checkpoint inhibitor, drugs which act by the same mechanism, are being evaluated. So BCG, there's a study which randomizes patients to BCG induction plus maintenance, adding durvalumab, and the third arm where maintenance is omitted but durvalumab is continued. Here the primary endpoint is disease-free survival, and another study where upfront randomization would be done to BCG versus BCG with pembrolizumab. So there is some kind of activity that we see with these drugs, not the kind of level that we want to, but still we need more refinement in this space, and this is a tough to treat disease at this point. So I think with this comment, I'll just wind up, saving enough time for the whole session. Thank you.
Question time. So we've got 4 questions. First question is, systemic immunotherapy, Pembro, can be offered to patients with, Systemic immunotherapy, Pembro, can be offered to patients with persistent recurrent CIS post-BCG therapy if seeking bladder preservation or unfit for cystectomy. Good. Next one is systemic immunotherapy. Pembro can be offered to patients with persistent recurrent high-grade PT1 TCC post-BCG therapy if seeking bladder preservation or unfit for cystectomy. Good. Alternative non-BCG intravesical immunotherapy can be offered to patients with persistent recurrent CIS post-BCG therapy within a clinical trial if seeking bladder preservation or unfit for cystectomy. Next, the last one. Alternative non-BCG intravesical immunotherapy can be offered to patients with persistent or recurrent high-grade PT1 TCC post-BCG therapy within a clinical trial if seeking bladder preservation or unfit for cystectomy. Good. This session seems to have a lot of values above 75. Great. Okay.
For the next talk, I request Dr. Harshit Garg to please come and enlighten us about the radical cystectomy for high-grade recurrences.
Thank you, organizing committee, for giving me the opportunity. So first of all, a very good afternoon to all of you. That's a loud good afternoon because I wanted to wake up. We had a delicious lunch, and half of us are dozing. We can see the voting percentages are going down. So I want you guys to wake up, and I'll, tell you, I'll not bore you. There is not much data. There is no percentages, 20, 30, 40 percentages. and half of my job is done already by Dr. Bora and Dr. Batra in their first slide saying radical cystectomy is the standard of care. So I don't know what consensus we are going to achieve here, but let's get the ball rolling. I have nothing to disclose. So this risk stratification, already most of us know about it as urologists. We have been reading it since our residency days. And so it's the AUA, there's EUAU. And what I'm interested right now is the high risk bladder cancer. And so that is the table taken from the European guidelines, which say, these are the percentages around 10% 5-year progression and 40% in very high risk progression rate. So let's come to the topic, that is high grade recurrence in non-muscle invasive bladder cancer. So what is the reflex response anyone gives to this? Yeah, radical cystectomy. So why are we even talking about it? So yes, are we doing something wrong? So absolutely not. So radical cystectomy and high grade recurrent non-muscle invasive bladder cancer is the standard of care. We know it, it is ingrained. And we, I always say use the term this BTR, which means we believe it that way since the beginning of our residency. We treat the people this way, and then we reinforce it, treating it again and again. And so it is in our, reflexes that whenever we have failures in recurrent non-muscle invasive bladder cancer high grade, we offer radical cystectomy. And this is not wrong. This statement from the European Urology Guidelines says it all, that treatments other than radical cystectomy must be considered oncologically inferior in patients with BCG unresponsive tumors. And the level of evidence is 3. So, recurrent high-grade non-muscle radical cystectomy, is it that simple? Of course not. There are some issues we are having here. So basically, when we are talking of recurrent non-muscle invasive bladder cancer, we are talking a gap between two standard of treatments. One, where we have a primary bladder cancer, where the TURBT and intravesical therapy is the standard of treatment. And the second entity is a primary muscle invasive bladder cancer, where we are talking about cystectomy versus bladder preservation, chemoradiation. But there is a gap, and that gap is recurrent high-grade non-muscle invasive. So let's come to a background a little bit. So when we are talking cystectomy in a primary high-grade non-muscle invasive bladder cancer, yes, it is the best cervical outcomes. But we were thinking there is some thought process that it could be an overkill. It has a major impact on quality of life, and various studies have shown that 10 to 15% patients even die after doing such a major surgery. And this was one of the feasibility trials by Dr. Cato and group, where they tried to randomly assign patients upfront for BCG versus cystectomy, and the results were I think many of us would know these results. And the BCG arm, 92% received the maintenance BCG, 4 had recurrence after induction, 3 had recurrence after 4 months, 4 received cystectomy, and 2 had metastasis. Not very impressive. Again, in the cystectomy, 5 of the patients did not have any tumor, and only 2 of the patients had muscle invasion. So it was an overkill there, and it was like, underkill there. So when we talk of recurrent non-muscle high grade, so what was it, a progression or a persistence? Then what is the time of the recurrence? When the intravesical therapy failed? What was the treatment he received? What is the risk stratification currently? And is it still non-muscle invasive or is it muscle invasive now? And what a variant pathology, which will be touched in the next talk after me. So we have got European guidelines, we have got American guidelines, and we have ample of data. So now we are at a robust level of evidence for a role of radical cystectomy in recurrent non-muscle invasive high-grade disease. So starting with European guidelines, so let's understand quickly the level of evidence so that we know what are we talking about. So they say level of evidence 1 to 4. Basically 1 is from meta-analysis or a good randomized controlled trial, while 4 is just from the expert opinion, and then they recommend basically strong or a weak recommendation. So when we have a recurrence after intravesical chemo, BCG is the standard of care, that's the level 1A evidence, and so prior intravesical chemo, whatever you receive does not have any impact on BCG. And now, if we have a recurrence after BCG, we have got certain terms which was coined by IBCG, BCG refractory, relapsing, unresponsive, and intolerance, which Dr. Bora covered very well in his talk. And patients with BCG relapse have better outcomes than the patient with BCG refractory, and non-high-grade recurrence is not considered as a BCG failure. So these are the definitions we already talked about. And so there's a flow chart where you say if it's unresponsive, if eligible cystectomy, do it. That is the key. If cannot do it, find a trial. Then if it is late BCG relapsing, then if you have an incomplete resection, still you can do a cystectomy if preferred, but if he doesn't want, then you can do a resection and then see if you need a cystectomy versus you can offer a repeat BCG in case you have a second TURBT and a low-grade tumor. Now, this was a meta-analysis for bladder-preserving protocols, various therapies published in European Urology, and both of them has said that the pooled 12-month response rate for with two BCG, two or more prior courses of BCG were given, the success was 24%, and if only one course was given, success was 36%. And I'll not waste time on this because we have to preserve time. And so, BCG unresponsive radical cystectomy is the standard and the preferred option. It's a strong recommendation from the European Urology guidelines, and repeat BCG therapy is appropriate for non-high grade and even in some high grade recurrence if they have recurred after 1 year of the therapy. And that's the same, same thing reiterated. ESMO guidelines also reiterate the EAU guidelines. And next comes the American guidelines, that are AU and SEO guidelines. They grade the recommendation as strong, moderate, or evidence as high certainty, modern certainty, or low certainty. And what do they have to say? That if it's a low-risk disease, there's no role of cystectomy. If it's a high-risk patient fit for surgery or persistent high-grade T1, carcinoma in situ, or variant histology, cystectomy should be recommended. And if it's a high-risk and persistent, especially after 2 courses of BCG, cystectomy should be recommended with a moderate recommendation and certainty strength of C. NCCN also follows the similar guidelines as like the AUA, the cystectomy is preferred. Quickly covering the recent studies in this regard, this was the paper from the Netherlands where they tried to see the outcomes of a progressive versus de novo muscle-invasive bladder cancer. And I think that's also, we know, that patients who have progressive muscle-invasive bladder cancer, that who have come from non-muscle-invasive to muscle-invasive entity, they are, they do worse, so they have a higher concomitant carcinoma in situ, they have higher surgical margins positivity, and even in terms of survival outcomes, their 5-year and 10-year survival outcomes were worse if they have a progressive MIBC as compared to de novo MIBC. And this is the recent paper, very well quoted and studied. This is a multicentric study from the European centers where they tried to do a retrospective analysis of patients undergoing radical cystectomy and divide 4 categories. That is primary high risk, that is upfront cystectomy in a high risk patient, recurrent high risk, then primary muscle invasive, and then secondary muscle invasive, that is who has progressed from non-muscle invasive to muscle invasive. A very comprehensive assessment. And what they found when we talk about recurrence-free survival, the 5-year recurrence-free survival was best for primary, was equivalent for recurrent non-muscle invasive and primary muscle invasive, and was worse for secondary muscle invasive. And this was similar in cancer-specific survival as well as in terms of overall survival. So and so that lymph node involvement in pathological upstaging was more common in the secondary MIBC. Recurrent high-risk MIBC was independently associated with shorter recurrence-free survival, cancer-space survival, and overall survival. Secondary MIBC was a shorter cancer-space survival and overall survival, and recurrent MIBC and MIBC remained an independent predictor for pathological upstaging. And so basically, the concept is that if you have recurrent high-grade non-muscle invasive, the prognosis is similar to a primary muscle invasive bladder cancer. So there were some limitations with this paper that the data on BCG unresponsiveness and persistent CIS was not recorded. The BCG protocol and follow-up strategy was not standardized, and patients who received neoadjuvant chemotherapy were excluded. So muscle-invasive bladder cancer, there was a bias in its outcomes. Then we have variant pathology, which broadly is considered a high grade, and cystectomy is considered standard of care, but I think Dr. Puneet would cover more on this aspect in the next talk. This was a paper we did from AIMS, 5-year analysis of the radical cystectomy, and we have 22% of patients who had high-grade endoscopically recurring or high-grade tumors. Of course, we did not do a long or survival analysis, but we see mainly the patients as T2 or T3 disease, and the peri-op complication rate was 23%, and 30-day mortality rate was 5%. So, concluding, saving 5 minutes here and concluding my talk, in a nutshell, I would just say that, non-muscle invasive bladder cancer is the Salman Khan who's trying to find a girl. He's browsing through many options, including Katrina Kaif, Aishwarya Rai, and then so many. But ultimately, you have to find a family. So both Katrina and Ashwita found their family, and that is radical cystectomy because that's the sustainable and long-term outcomes. Thank you.
So that's your Katrina cystectomy now. I'm going to interrupt the program for 1 minute. 7:15, Dr. Mani Menon comes live from the US for an exclusive talk for us, followed by dinner. Before that, there will be a patient awareness campaign and award ceremony. Some of it has been announced before, some of it has not. And I just wanted to clarify that Mani Menon today is going to receive a massive award from us, which is accepted. And also, he wanted to address us both on a scientific topic and an informal interview, which you will enjoy. Looking forward to your presence between 7:15 to 7:30. Let's carry on.
Thank you, Harshit. That was a fantastic lecture. You know, it woke us all up. I think his voice is still ringing in my ears. The next set of questions, radical cystectomy for high-grade recurrence or persistent disease. We've got about 8 questions. The first one, radical cystectomy should be offered for persistent CIS post-induction BCG. Can you go back once, please? So I will. All right, so we let it go. So statement 2, radical cystectomy should be offered for persistent high-grade PT1 TCC post-induction BCG. No, I think it's changed, is it? Can we do it the next session? Okay, so let's go on with the next talk. Saurabh, come back. So we'll have to change the options out here. So we'll come back to it at the end of the next session.
So I request Dr. Puneet Ahluwalia to come on the dais and enlighten us about the management of variant histology in CA bladder.
Good afternoon, everyone, and thank you so much for this opportunity. The topic for my today's talk is management of variant histology in non-muscle invasive bladder cancer. So we know that urothelial carcinoma accounts for 90% of the bladder cancers, and 2022 WHO classification of urothelial carcinoma divides it into non-invasive urothelial carcinoma and invasive urothelial carcinoma. Non-invasive includes papillary and CIS, whereas invasive urothelial carcinoma includes conventional urothelial carcinoma and variant histology. Now, this classification is slightly different from clinical classification, that is muscle invasive and non-muscle invasive, which we use for our treatment purposes. That classification serves well for treatment. But this is a pathological classification which tends to tell us about the biological behavior of the tumor. And it makes sense because not all non-muscle invasive bladder cancers behave similarly. So when we talk about variant histology, we should know 2 things. One is divergent differentiation, the other is subtype. So divergent differentiation means the tumor has differentiated along a different epithelial line altogether, that is squamous or glandular or trophoblastic. Whereas urothelial subtype, the primary urothelial lineage is maintained. So, and one more thing we should know is that now we use the term subtype instead of variant. Variant is used mainly for genomic alterations, and we use the term subtype now. However, for the purpose of my talk, I will use these terms interchangeably because the literature has used variant for all the studies. So we have multiple subtypes of urothelial carcinoma. Now, when we talk about variant histology, we should know how common they are, what are the diagnostic implications, whether there are any genetic alterations which can help us in diagnosis and therapeutic implications. Also, we should know whether the prognosis and survival is any different as compared to pure urothelial carcinoma, and what is the ideal follow-up protocol for these patients. Now, variant histology or subtype histology is significantly underreported and underdiagnosed. The TURBT shows a relatively low accuracy ranging from poor to moderate in diagnosing these patients, and we definitely need more additional diagnostic tools to identify these variant histologies. So it is significantly less reported as compared to the histology on final radical cystectomy specimens, and this may be because TURBT1 may provide lesser tissue, but also there may be an element of not having an expert uro-oncopathologist or not having a very high volume centers who see these sort of tumors daily. So with increased number of cases, with increased experience, you may see them more often in your reports. And this low accuracy in reporting variant histology has been seen across multiple centers and across different subtypes of variant histology. So the discordance is there for all the variant histologies, majorly for micropapillary, and neuroendocrine was one tumor in which there was highest concordance rates. So that was on the other spectrum. So before going further, let's have an overview of the behavior and treatment of these variant histologies. So if you talk about divergent differentiation, so these tumors are managed as for pure urothelial carcinomas, stage to stage. For as you would manage a particular urothelial carcinoma, pure urothelial carcinoma for a particular stage, you would manage these glandular and squamous differentiation similarly. However, when you talk about other subtypes like micropapillary is the most common among these. Then these other subtypes usually present at advanced stage and they have a higher metastatic potential, and upfront surgery has been recommended for these other subtypes. If you talk about small cell or neuroendocrine, this is one subtype in which chemotherapy should be considered first. So as we know that the diagnosis is difficult and it is significantly underreported, so studies have tried to evaluate the molecular mechanism associated with these subtypes, also gene studies. So these molecular mechanisms may help us in making a diagnosis, and also they can guide us about the suggested treatment line, the effect of chemotherapy, the effect of immunotherapy. Chemotherapy is well known to be effective in these tumors. Whereas the immunotherapy results are, long-term results are pending, but the results are encouraging. And micropapillary, which is the most common, if you see the gene profile on the right side, the upper half is red. That means the that different genes are overexpressed. So that is the change in that. And this causes the high aggressive nature of this micropapillary. And what these genes are, there are various genes like G1, S checkpoints, cyclins, cell cyclins, what we study. So I would go deeper in micropapillary variant specially. So it has a strikingly male predominance with high recurrence and progression rates and 22% reported metastatic rates. The upstaging rates on radical cystectomy are also quite high to the tune of 73%. They may present at an advanced stage with higher rates of lymphovascular invasion, carcinoma in situ, and lymph node involvement. And the consensus of the best treatment for T1, that is non-muscle invasive micropapillary bladder cancer, was radical cystectomy and BCG only in very selected patients. Now, if you do a radical cystectomy for these T1 micropapillary tumors, you may have cancer-specific survival rates, 5-year cancer-specific survival rates to the range of 80 to 100%. But for TURBT and BCG, it is 60 to 85%. This is based on 758 reports, more than 3,000 patients. And use of neoadjuvant chemotherapy, if you use that, you may have a much higher complete pathological response to the tune of 50%. However, the neoadjuvant chemotherapy does not improve recurrence-free survival or overall survival. And 53% of patients who underwent RC alone and not along with that chemotherapy had locally advanced T3, and 43% had node positive disease. So micropapillary, although radical cystectomy is shown to have better cancer-specific survival rates, but it was not significantly associated with, micropapillary was not significantly associated with worse recurrence-free survival, cancer-specific survival, or overall survival. Now, the data is a little bit conflicting also. There are some contradictory reports available also. So this is a study, but the sample size is very small. There are only 36 patients. And in this, it was seen that it is not always that radical cystectomy may be a better option. And patients who are managed conservatively may actually have a similar outcome in terms of oncological outcomes. And so to know what these patients are, how can you differentiate these patients which may do worse with bladder preservation? There was a study, and they defined that micropapillary urothelial carcinoma has a heterogeneous prognosis, and the patients who have LVI, or then they further divided micropapillary into invasive histologically and a superficial micropapillary histologically. So invasive micropapillary and patients with lymphovascular invasion, they had a worse prognosis, whereas superficial and no less lymphovascular, they can be managed conservatively. If you talk about chemotherapy, so in T1, T2 organ-confined disease, chemotherapy in micropapillary actually does not reduce cancer-specific mortality. It is helpful in metastatic micropapillary or a non-organ-confined, but for non-muscle invasive or even organ-confined T2, chemotherapy actually may not be much helpful. So what about the survival and follow-up of these patients with different subtypes? Now, radical cystectomy has been shown to have a better overall survival for patients with various subtypes, including sarcomatoid, squamous, glandular, neuroendocrine especially. But micropapillary, again, it is a controversial data. So overall survival benefit was not observed in this study with the micropapillary variant, suggesting a potential role of bladder preservation as discussed. So another study, actually it studied variant histology and variant subtypes. So suggested that variant histology and various subtypes are significant predictors of disease-free survival, and also variant subtypes also significant predictor of cancer-specific survival. So you see in the graph, basaloid, glandular, nested, all these are aggressive as compared to the pure urothelial, and villus-like tumors or microcystic, they have a better prognosis. So this study divided these variant histology tumors into low risk, very low risk, and high risk, and then for very high risk tumors, you tend to go and do radical cystectomy upfront and bladder preservation. This was another paper which was published 2-3 years back. They tried to develop an algorithm for treatment of patients with high-grade T1 and variant histology. So micropapillary, sarcomatoid, plasmacytoid, in these study, patients go for immediate cystectomy. Or for others, you can do a re-TURBT and then evaluate if it's a recurrent persistent high-grade, then do a radical cystectomy. What about the surveillance? These patients have higher recurrence rates and over a longer period of time. So on an average, for a urothelial tumor, you follow up for 6.5 years. For these patients, you have to do a follow-up for 10 years. And micropapillary variant confer the greatest risk for abdominal and lung recurrences, whereas other mixed variants metastasize to bones and other sites as compared to urothelial carcinoma. So my take-home message is so that variant histology is quite common, 20 to 25% of cases. There is significant underreporting and inter-observer variation. There's accurate identification is important because it exhibits aggressive biological behavior and it will affect treatment and the final outcomes of the patient. There is a discrepancy between the TUR specimen and radical cystectomy in diagnosis, and upstaging is quite frequent. Stage to stage, however, most subtypes you can treat like pure urothelial carcinoma. The differences in outcomes are not much except for neuroendocrine and plasmacytoid variant, and possibly for pure squamous cell carcinomas. Pure squamous and adeno are generally treated with surgery alone, whereas neuroendocrine, you have to give chemotherapy first. Thank you.
Right, so we head back to the previous session. Yeah. Right, so this is the first question in radical cystectomy for high-grade recurrence or persistent disease. Have we done this already? No. Okay. So, first question: radical cystectomy should be offered for persistent CIS post-induction BCG. Right. Next. So radical cystectomy, question 2, radical cystectomy should be offered for persistent high-grade PT1 TCC post-induction BCG. Right, good. So some of the questions may seem rhetorical, but they're actually very well thought out questions. So please give a thought before you answer. Minimally invasive robotic/laparoscopic radical cystectomy should be the standard surgical approach for cystectomy. Extended pelvic lymph node excision should be the standard of care during radical cystectomy for NMIBC. Right, that's interesting. Frozen section at ureteric margins should be performed in all patients undergoing radical cystectomy for high-grade non-muscle invasive bladder cancer. I'm sorry? NMIBC, yes. So we do, Dr. Kochikar, we do cystectomies for NMIBC. So I think we're trying to get this part of it. Right, question 6. All patients who have had a radical cystectomy for NMIBC should have lifelong urethral surveillance with ureteroscopy or urethral barbotage. Question 7. All patients who have had radical cystectomy for NMIBC should have lifelong upper urinary tract surveillance. Last questions. A statement, all female patients undergoing radical cystectomy and urinary diversion for high-grade NMIBC should have the uterus and ovaries removed at the same operation. Good. So we go to management of variant histology, and we've got 9 questions here. Question 1. Radical cystectomy should be offered first line to patients with NMIBC and micropapillary differentiation. So radical cystectomy should be offered first line to patients with non-muscle invasive bladder cancer and squamous differentiation. So question 3 is radical cystectomy should be offered first line to patients with NMIBC and sarcomatoid differentiation. Good. So just to clarify, I think when we say differentiation, sarcomatoid or micropapillary, we should assume that it's a good amount of differentiation, not just minuscule differentiation in the pathology or something like that. Yes. So next is radical cystectomy should be offered first line to patients with NMIBC and neuroendocrine differentiation. I think some of us are pressing one particular alphabet because we like it, or is it just things? Okay. The next question is radical cystectomy should be offered first line to patients with NMIBC and plasmacytoid differentiation. Good. Radical cystectomy should be offered first line to patients with NMIBC and glandular differentiation. So question 7 out of 9, radical cystectomy should be offered first line to patients with keratinizing squamous metaplasia of the bladder. Right. Question 8. Intravesical BCG therapy can be offered to all patients with NMIBC and variant histological features, except small cell neuroendocrine variant. We're giving you time to think on this one. Yeah? Okay. Last question. Neoadjuvant chemotherapy should be offered to patients with NMIBC with small cell neuroendocrine variant histology. Good. Thank you.
For our final talk, I'll request Dr. Vivek Venkatramani to come off the dais.
Good afternoon, everyone, and many thanks to the organizers for this opportunity. So as we all know, bladder cancer remains a significant public health problem. It's a very common cancer. It is quite lethal, and there is a significant treatment associated morbidity, whatever treatment one uses. What is also unique about this cancer is it has the highest lifetime treatment cost per person of all cancers, and that is especially true for high-grade NMIBC where long-term surveillance is needed. So there is no question that there is a tremendous scope for improvement and further research has to be done. So all the previous speakers in the bladder session have, done my job in terms of the recent advances in imaging, BCG failure and treatment. So I'm not really going to be talking too much about this. When I looked up and started studying about this particular topic on clinical trials, bladder cancer, there are 510 active studies. And in the last 1 year, there were 3,002 publications on bladder cancer. But a lot of them may not be of much clinical utility at the moment. So I thought I'll kind of structure my talk in 3 themes. One is about the urinary microbiome, the tumor microenvironment and the use of biomarkers, and AI and machine learning and where they may take us in the next few years. So there will be some overlap with MIBC as well, but these are 3 themes which I feel could impact bladder cancer in the next decade. So the microbiome basically refers to a community of microorganisms and their genetic material existing naturally in a particular environment, which includes part of the body. The last 10-20 years, we've seen an explosion of research on the gut microbiome and its influence on chronic diseases and even systemic metabolic diseases like diabetes and obesity. And that's given rise to a treatment of fecal transplantation. So similarly, the common dogma that urine is completely sterile has been found to be not completely true. It does have a microbiome of many commensal species, and there are age and sex-related differences. And chronic inflammation, as we all know, can be a precursor of malignancy, as in schistosomiasis. DNA damage, carcinogenic metabolites, and inflammatory mediators play a role. And similarly, this dysbiosis may also give an idea about the pathogenesis of chronic pelvic pain syndromes or interstitial cystitis and other benign diseases. With regards to bladder cancer, it's still an early stage. There are conflicting results about the type of bacteria that are seen. One study showed 5 suspect genera in tissue samples, and another study showed different bacteria which was studied in the urine of bladder cancer patients. But what seems to be consistent is that there is a significantly decreased microbial diversity noted among cancer patients. So that may be a potential way that we may get novel therapeutic targets, as well as it helps to predict the response to intravesical or immunotherapy. These are ways, avenues that can be opened up for research in the future. In fact, this is a class at ASCO this year itself. This refers to colorectal cancer, where the use of the microbiome is in predicting the response to immune checkpoint inhibitors as well. So they may serve as a biomarker of disease in the future. So since I've been a urology student, we've been hearing about biomarkers for urinary bladder cancer, I think last 10, 15 years, probably longer. We know that they have to be accurate, non-invasive, rapid to analyze, easy to perform, reproducible, and cost-effective. Until now, we haven't beaten cytology. But nowadays, with newer techniques, the analysis of tumor microenvironment helps us to uncover potentially new biomarkers, which may give a better understanding of the disease. So biomarkers for bladder are unique because we have access to the urine as well as the blood. And the problem with urine is that the DNA concentration is quite low in early stages in the urine, and it's difficult to identify in urine samples early in the disease. Urine cell pellets are then centrifuged to use for DNA mutation analysis, and these have been studied in hematuria evaluation as well as in the surveillance of NMIBC patients. Urine-free DNA with hypermethylation, the bladder EpiCheck test has been shown to be superior to cytology in NMIBC follow-up, and there are other markers under evaluation for hematuria patients and risk stratification of these cases. So this is something which is going to play a potential role in the future. We've been saying that for a long time, but I think now is the time where the tide has probably turned. Exosomes are extracellular vacuoles containing tumor differently expressed genes, and they have also been studied in diagnosis, risk stratification, as well as selection for adjuvant therapy, and have been shown superior to cytology in some studies. mRNA, there is an expert bladder cancer monitor which studies 5 target mRNAs and is used for NMIBC follow-up. And similarly, you can detect cancer cell metabolites in hematuria population to diagnose bladder cancer. There's a whole list of proteins that have been studied in the urine which are sensitive. PD-L1 in urine is associated with carcinogenesis and a lower response to BCG. And ADX bladder, if negative, you may even omit a cystoscopy in low-grade patients. Similarly, we have a whole panel, OncoUrea panel, which studies a large number of proteins. So urine-based biomarkers, they are promising, and 4 actually from the EAU guidelines are commercially available: CX, ADX, expert bladder, and EpiCheck. They may approach the sensitivity of cystoscopy, and if they are cost-effective, they may help in reducing the overall cost burden of this particular disease. However, they need to be tested in RCTs, and we always hold the risk that this may actually happen when they are studied in RCTs, but hopefully that won't be the case. MicroRNAs are kind of a unique molecule. They can be detected both in the urine and blood. That's why I kept them in the middle. And they affect the tumor microenvironment in a variety of ways, and all these can be studied to detect recurrence and progression. Moving on to blood. Blood, basically we are looking for circulating tumor cells, ctDNA, RNA, and again exosomes or metabolites and proteins. Blood allows dynamic assessment and real-time monitoring. CTCs actually less than 0.01% actually produce metastasis, and assays are being used to see detection of cancer cells. ctDNA has a more important role. We'll go through that in a little bit detail later on. Exosomes, metabolomics, proteomics. The problem with blood-based biomarkers at present is the lack of standardized assays, the cost, and the need for larger studies to validate them. Tumor heterogeneity within the tumor and between a primary and the metastasis may also play a role in their exact value. So when we look at the application, detection of tumors, whether for screening in high-risk groups or early diagnosis in a hematuria patient, these have been studied. Classification and prognostication of tumors, progression and recurrence of disease even before imaging. So 90% of those with a circulating tumor DNA positive post-cystectomy will relapse, versus only 10% if it's negative. So that you may tailor your imaging based on that. And this is a great podcast episode which I heard recently, which gives a better picture of how to use this circulating tumor DNA. And progression or recurrence of the disease even before imaging, this is where the microRNAs have some role, and there are numerous other assays. And ultimately, we are hoping that this will give us treatment targets, especially in advanced disease, may predict chemoresistance, and monitor the efficacy of this treatment. So basically, every path of the bladder cancer, right from genesis to metastatic disease and monitoring, could be impacted with the role of biomarkers in the next few years. So that's why I feel that this is one area which is pretty promising. So these are just some upcoming trials, which is all again post-cystectomy, and there's a large number which are using biomarkers to tailor treatment and to assess response to treatment. So I feel that this kind of suggests that we are reaching a turning point in the use of biomarkers. And finally, about artificial intelligence, a new buzzword, and it's basically AI is intelligence demonstrated by machines, perceiving, synthesizing, and inferring information, enabling to make decisions and solve problems. And similar, machine learning is a study of computer algorithms that helps to find patterns and make predictions. So radiomics is a quantitative approach to medical imaging, and it quantifies textural information using analytic methods from the field of AI, and it enhances the information available to the clinician. So this may help in predicting MIBC on an MRI. There's a meta-analysis on radiomics which showed a good sensitivity and specificity in predicting MIBC, and these are things which are being worked on at present. Similarly, to detect lymph node involvement, it can be used even in the PET scan and to assess recurrence post-bladder preservation. Radiation treatment planning, you contour it automatically. You can make it much more efficient. The technician may not always need to, be in the room. The radiation oncologists are never in the room, but even the technicians may not need to be there if they are contoured by the computer. Similarly, we had a great talk in the prostate session last week about pathology, how machine learning algorithms would help the pathologist and augment the pathology, make it rapid in terms of the turnover. We may not have to wait too long for pathologic reports. It can provide an automated prediction of the presence of cancer as well as the invasiveness and grade. So this was one study which used an artificial intelligence derived gene signature, and those had a high risk, a high score had a high risk of mortality, recurrence and progression. So this is how it was done, again through circulating DNA and AI combined. So that may be another area where combination of biomarkers with AI and machine learning will help us to reach much more better accuracy in terms of predicting different things. Finally, a bit about AI with cystoscopy. So this was a nice study which trained a neural network with more than 10,000 images to identify tumor and the grade based on white light and NBI. And so based on the tumor color, the AI was able to diagnose tumor, benign versus tumor, and predict CIS versus inflammation with a success rate of more than 98%. So maybe we won't even need a pathologist. We can just show it to the computer and get our diagnosis. But okay, fair enough. But just a caveat, all AI is based on how you train it, and similarly for the machine learning. So if there's garbage in, there'll be garbage out. So, big data and a lot of monitoring, quality assurance, and, retraining is also important and not just trusting it blindly. So I think bladder cancer, I'll conclude, is a significant health problem. We need to do a lot more research, and it is ongoing. Microbiome may provide some clue on etiopathogenesis. Biomarkers will play an increasing role in diagnosis, monitoring, and treatment planning, and AI will increasingly impact the diagnostic pathway at least. And the combination of both may be the future. So thank you.
So the next set of questions, you may be right if you press any alphabet, but if you have absolutely no idea what's going on, just press F. So, yes. So this is about future research themes, and the first statement is genomic profiling for high-risk non-muscle invasive bladder cancer. Good. Next statement is nanopharyngene installation for high-risk non-muscle invasive bladder cancer. Next statement, photodynamic therapy in high-risk non-muscle invasive bladder cancer. Statement 4, erdafitinib for NMIBC progressing on BCG. Right. The last question statement, intravesical gemcitabine plus docetaxel versus intravesical gemcitabine versus intravesical BCG as first line of adjuvant therapy for high-risk NMIBC. Sorry? I think we need to change the... So let's skip this. Right? I think Dr. Vivek gave a tangential talk compared to the questions that we have right now. But if I may, a quick word of advice to Dr. Vivek, you should put pictures of Aishwarya Rai or Katrina Kaif instead of bodybuilders and stuff like that. So, Saurabh, we're going to open the floor to questions. I would skip the last question. I think we're not taking that, right?
The house is open for question and answers. If anybody has questions, we can have.
I would like to ask from any of the panelists, when we talk about responses in BCG, we talk about 60 to 70%. And then we talk about second and third line, we are going down to about 30 or 40%. So what is the general consensus? What kind of is acceptable, or if FDA approves it, at what level of efficacy of CRPR, and then how long should that be to actually get approval? Have you any idea at what levels are they accepted?
Before moving on, I would request our respected chairpersons to have final concluding remarks. Respected chairpersons, please, your concluding remark.
I think it was a wonderful session, and I think though the theme was recurrent, most of the things are always, there's a lot of, because it's the same thing again and again. But we know that the unfavorable histologies require upfront cystectomy. That was the basic thing there. And BCG failures, there are lots of alternatives which are coming up, and hopefully in future you may have an alternative. But as again concluded, the radical cystectomy still remains the treatment of choice. All, whether it's retroviral gene therapy or combination of various drugs, these are all producing response, but not enough to actually call them as a standard line of therapy. And I think Vivek's talk on the future about biomarkers, I must say that from the time I joined urology, biomarkers have been in the news. Until today, we do not have one. So I really hope that situation changes, at least Vivek, in your active lifetime. Thank you very much.
Thank you so much, respected chairpersons, all the speakers, and Dr. Ananth Krishnan. So moving on, I request Dr. Kochikar sir to take the charge and discuss this tumor board.